Yeah, so the good news about this case is that there are a number of therapies. If you assume that the patient is relatively asymptomatic, her bone pain's gotten worse, but she's still managing her pain with maybe an occasional narcotic, maybe at night to sleep, but other than that is doing pretty well, then you really, in my practice, want to avoid chemotherapy at most cost. Even with multiple liver lesions, patient's liver function can still be good. And remember, this is a woman that just 3 years ago had gotten our best chemotherapy, adriamycin, Cytoxan, and paclitaxel. So I'm not real inclined to jump back on the chemotherapy bandwagon at this point. So what has she not had in the endocrine domain? She's not had tamoxifen. She's not had a type 1 aromatase inhibitor, which is exemestane. And that's it. And so what you want to do is think about incorporating anti-estrogen or endocrine therapy, but it always makes me feel a little bit better if you can layer a targeted agent on top of that. And so in this patient, my choice would be exemestane everolimus based on the Bolero-2 data. I was quite impressed, at least in the New England Journal of Medicine publication. The independent review showed a 6-month improvement in progression-free survival. And so the way I would describe my recommendations to the patient is I just really don't want to start you on the chemotherapy pathway at this point. And we have 2 anti-estrogen therapies that you've not had, both pills, exemestane or tamoxifen. And then we have a targeted agent known as everolimus that's been shown to make both of those drugs work better. So I would sit down and talk to her about that. I think for very practical, data-driven reasons, I would elect to use the exemestane. If she was reluctant to do that because she had a tough time with side effects on the anastrozole, then you can also consider the use of tamoxifen, as that's been studied also in combination with everolimus.